So our SHIELD law, again, is a number of provisions that kind of work together that are designed to, we've said, reproductive rights and access to gender affirming care too, which I think is a really important thing to acknowledge. We know that the states that are banning abortion are the same ones that are attacking particularly youth access, but access to LGBTQ healthcare and gender affirming care in particular. What our state said is those are core rights and secured by our laws and our constitution in Massachusetts. And so we designed a number of statutory provisions to say we're not going to let other laws in other states reach in, whether it's through litigation or restrictions in other states, to say the care that we've deemed protected here is going to be impacted. So it primarily does a lot to protect providers of abortion care, of reproductive health care and gender affirming care, by saying that, for example, if you're, a clinician and you are sued by somebody in a medical malpractice claim, that might have an impact on your license, right? It lives on your profile publicly. Most likely, you could be disciplined in some way. What our SHIELD law says is that if a clinician in Massachusetts is sued under what we call abusive litigation by a harmful actor in, say, Texas or Oklahoma or Mississippi, for care in Massachusetts that we've said is legal here, you cannot be disciplined professionally for that type of litigation. You can't have your license revoked. You can't have it ding you or discipline you in any way. We've also said that our courts are governed by Massachusetts law. So our courts will not recognize, or we put a lot of guardrails in place to make sure that they don't respond to subpoenas, requests for information about legally protected healthcare. We're doing, again, kind of everything in the power of a state government to say we're going to use every tool available to us to make sure our laws govern here and our laws are governing legally protected healthcare here in Massachusetts. We also did in that SHIELD law was protect telemedicine providers as well. So we said what we're saying is legally protected healthcare activity is what we've deemed to be allowable here in Massachusetts, regardless of where the patient is located. So if a provider is based in Massachusetts and providing abortion care that we've, again, deemed as a right here in Massachusetts, that patient could be in California, they could be in Texas, they could be in Oklahoma, they could be in any state. And so it has allowed for the proliferation of SHIELD law practices like the MAP that are, according to our law, practicing abortion care here in Massachusetts and making it available, medication abortion, by mailing it to states across the country. We're lucky to call what we passed our SHIELD law as best in the nation. And I think it has really served as a model for other states that saw that and took action to pass SHIELD laws after in 2022 and 2023. I think Massachusetts did do a tremendous job recognizing that there was work that we need to do to ensure that abortion remained protected in Massachusetts if Roe v. Wade were to be overturned. In many ways, advocates in the legislature worked to understand and see the writing on the wall there, to see that that was coming and that it was approaching. And so in legislation that was passed at the very end of 2020 did codify the right to abortion into our state law. And I think what we at Ren always focus on, and I think providers and folks here would recognize too, is that especially as we see all of these bans across the country and trap laws persist against providers, that a legal right is not the same as an accessible one, right? And so that legislation also started to do really important work to expand access to abortion. It expanded the types of clinicians that can provide abortion care so that it's not just doctors, but also nurse practitioners, nurse midwives, physician assistants. It also started to expand access to abortion later in pregnancy. I think maybe we'll have the opportunity to talk a little bit more about that, but Maureen mentioned that there are 20 states that still have bans at a certain point in gestation. You might not think Massachusetts has an abortion ban, but we do have a restriction at 24 weeks. So it started to kind of expand access to abortion later in pregnancy. It lowered the age of consent for minors to access abortion care without parental involvement. We have more work to do there as well. If you're 16 or under, you still need parental consent to access abortion care. But it started to do a lot to again, codify the right in Massachusetts so that we knew that abortion would remain protected if Roe fell, and start to expand access to it. And then when the Dobbs decision came down in 2022, we worked very closely and were lucky to work with a legislature that was very ready to take action in 2022 to say again that Massachusetts, with the Shield Law, is doing everything in its power as a state government to say that whether it's the federal government or other state governments are not going to reach in and impact what we've deemed to be legally protected care here. Yeah, well, I think the Shield Law is, again, I used this term before, but designed to innovatively be an architecture of laws working together to say this is what our state government is deeming legal and protected, and saying this is the reach of our state government that's not going to be impacted by other state laws. So these are laws that are certainly being tested in other states in federal court. There are providers in New York that are facing both civil and criminal charges from states from Texas and Louisiana for mailing abortion pills into those states allegedly. And we're seeing that test of the Shield Law, and it's been very impressive, I think, the ways in which various levels of New York's government has said, no, this is the way that our laws are governing these types of litigation, and we're not going to allow any request for information or any charge against this legally protected healthcare impact the ability for our providers in New York to be protected. So yeah, I think they are, again, in the way that they're very innovative. We are seeing the first challenges of them in the courts now. And there might be ways that they are changed in the future in the ways that these court cases continue on. But for now, again, the model of Shield laws is state governments saying we're deeming what laws govern our practice of medicine here in Massachusetts, and saying that we're protecting the provision of this care as if it were happening inside of Massachusetts. The states that are banning abortion, if you look at a map, it's the same states that are banning access to gender affirming care. So I think Massachusetts and other states have done a good job of acknowledging that as we are protecting care within our Commonwealth, we're acknowledging that it's reproductive health care and care that allows people to secure their own decisions about their body and their own bodily autonomy. And that means gender affirming care as well. I think maybe I'll take a moment just to share what some of the updated legislation is that Massachusetts is considering, because it is really comprehensive. It's taking a look at data collection with regard to reproductive health care and gender affirming care, and making sure that no personally identifying information or disaggregated data can be shared or disclosed from people who are collecting it. Dee Dee mentioned that the state collects a tremendous amount of data. We do abortion surveillance, and that informs our public health infrastructure and can be used for really important things. But we also want to make sure that none of that information, particularly identifying information, can get into the hands of bad actors. So that's a really important piece. We talked about privacy and people feeling fear about telemedicine. One thing, Reproductive Equity Now's foundation runs an abortion legal hotline, which connects both patients and providers to free legal guidance about their rights to either provide or access care. And one thing that's not uncommon for us to receive questions about is people who are considering traveling to Massachusetts for abortion care, or anybody from a state that is hostile to reproductive health care or gender affirming care, and asking what happens when I come back home and my providers at home either ask what happened or see information about that care that I received in my medical record. And so another thing that's really important that this legislation contemplates is putting some guardrails in place and firewalls and who has access to our online medical records. Electronic medical records and the interoperability of them has been a huge way to expand access to care. And also, as we kind of contend with this idea that there are so many people looking to use that information in nefarious ways. We have to be thinking about how we protect who can see it, and put some guardrails in place to make sure that patients have the ability to affirmatively consent to who can and can't see information about reproductive health care or gender affirming care. So I think those are just two pieces that, again, the legislature has been very proactive in understanding that the threats to both of these types of care are very interconnected. And again, all about a campaign of control and stripping away bodily autonomy. And so we should be intentional about protecting all of that care. Medication abortion has really increased in demand and popularity in the past several years. And that's because, partially because mifepristone, which is the first drug used commonly in the 2-drug regimen for medication abortion, is extremely overregulated by the FDA and has been for the entirety. It was approved for as a medication by the FDA in 2000. And since that time has been governed by what's called a risk evaluation and mitigation strategy by the FDA REMS. And that has, we've seen the restrictions on mifepristone loosened in recent years, particularly. It really proliferated in the pandemic, the allowance for prior to 2019, 2018, you had to go in person to a clinician to be receiving the pills in hand. You've never, up until recently, you've never been able to access mifepristone like you would pick up any other prescription from your pharmacy. So that's a really new allowance. And in 2019, 2020 was really when the federal government said it's unsafe, of course, with the global pandemic, for people to have to go in person to their healthcare provider. And so we're not going to enforce this requirement for people to pick up the medication in person. And so that's when telehealth of medication abortion really started to grow in demand and popularity. And in 2021, I believe the FDA officially loosened that restriction to make sure that people don't have to go in person. But there have been iterations of requirements from the FDA that have required 3 in-person visits to receive a medication abortion. They've extended the duration of gestation through which you can prescribe medication abortion. It was previously only up until 7 weeks, and now, as Maureen described, it's through 11 weeks of pregnancy. But so there are various challenges in the courts that we have seen to the FDA's approval of mifepristone, and essentially what they're trying to do is, despite its over 2 decades of safe and effective delivery of abortion care to people, millions of people in the United States, they are trying to challenge the fact that it's a safe and effective medication, and reintroduce those restrictions on medication and mifepristone specifically. So if, there are new restrictions imposed on mifepristone, we could see the prohibition on mailing medication abortion pills to patients, regardless of whether it's in state or across state lines. That would be obviously a huge hit to the care that the MAP is doing, and to the popularity of medication abortion and telemedicine abortion. I think it's 20% of all medication abortion care is provided via telemedicine. And as Maureen said, nearly 2/3, definitely over 60% of all abortion care is medication abortion care. So they want to restrict the mailing of mifepristone to via telehealth. They want to rescind, again, the duration of pregnancy through which you can prescribe medication abortion pills to an earlier number of weeks. And both of those things, I think, are really, rescinding access to people who have been able to utilize this pill. Of course, I think hearing this talk about, the importance of having procedural abortion on the island, I think drives home that at the end of the day, what we want is for people to be able to access the care that they need and they choose and they want in their own community. And that should certainly be medication abortion if that's what you would choose. It should be a procedural abortion if that's what you would choose. And ideally, I think we all live in a world in the future where it's not so othered from other healthcare. It's accessible at any type of provider's office instead of a specialized one. But it is really concerning that we see these challenges to the FDA's approval of mifepristone continuing to proliferate.
I like the optimism of this. What is the road back to full Roe v. Wade in country? A couple of years ago, I did a series about the Supreme Court, helpfully found on Paramount Plus and Showtime, should you want to tune in. And one of the episodes is about the abortion decisions and the road to Roe, and then the road afterwards. So one thing you all should know is Roe v. Wade was incredibly not controversial. It was 7-2, with Nixon-appointed judges joining in the majority and saying that this was a federally protected constitutional right to privacy. This Supreme Court upended decades of precedents in order to overturn Roe. So we do not see any road to coming back to a Roe v. Wade kind of decision with this current court. So there's lots of conversation about there's nothing magical about 9 justices. You could have more justices. That could open a can of worms, but that's the kind of conversation that there is. But we probably, to be honest, we probably will not see a nationwide constitutional right to abortion protection in the United States in any of our lifetimes. So I think that that's the sad answer to that question, unless anybody else disagrees.
No, I don't disagree. But the only thing I think I would add on is to remind us all that Roe was certainly the floor and it's not the ceiling of what we should be reaching for. And Maureen, described when she started us off in saying that there were thousands of restrictions already, targeted restrictions of abortion providers, restrictions in states that were already impacting the ability for already marginalized communities to access care. We have a tremendous amount of work to do, even in Massachusetts, to make sure that there's access to abortion care in every community and throughout pregnancy and for young people. And so I think that as we think about what it means, this is really the moment for states to be working towards expanding access. That's, purportedly what, as Don said, Dobbs said to do, is hand these decisions back to the states. And so I think we have a real obligation to be building an even better vision of how people access reproductive health care in their own communities than they ever could previously.